So don't be alarmed. Thank you, Alyssa. Yeah, welcome everybody. I think we're really excited to be talking about this topic today, which is early psychosis in the context of correctional systems. I think it's something that our group has put a lot of thought into and would really like to be approaching more thoughtfully. So what are the issues that affect people in the programs that everyone here is working with, and also what are the larger systemic issues that we should be thinking about. So very excited to have Joanne Wojcik and Rakesh Karmacharya today to talk about their experiences as clinicians who have worked with First Episode in trying to do some work in correctional systems. So by way of brief introduction, Joanne Wojcik has worked with our team, which previously was the Commonwealth Research Center, now is the Psychosis Research Program, but here at Beth Israel for over 25 years, so for a long time, and has also during that time volunteered in a prison system, so doing some work there, which she'll talk more about today. And then Dr. Rakesh Karmacharya is the medical director at McLean's On Track program, so doing First Episode work there, and also had an initiative that he'll talk more about today with you all. I think that I'll stop it there, but I'll start sharing my screen with Joanne, your slides, and feel free to take it away.
Okay. So we're going to, and yeah, can we put it on? Yeah. And then get rid of that. We'll go to the next one. So this is the most recent slide I could tell. What I'm going to start with is a description of the Massachusetts Department of Corrections system. So briefly, just to have everyone be on the same page with it. This is a slide from the 2018, maybe, when there were more people in the prison system, jail system. The local jails had almost 10,000 people, and that's remained pretty constant. They still do. I was able to look up today's, this year's population. It also includes state prisons. Now that has come down a lot, and I'll talk about that some more. Federal prisons, and then youth and involuntary commitment. So youth includes juvenile justice facilities, as well as like group home kind of places. So go ahead, next one, please. So I think what's important is to look at the number of people, and I think the total is being, Kelsey, can we like either move our pictures over or do something? So I think the important one for First Episode Psychosis is that the vast majority of inmates are 29 and under, with the next biggest group of 30 to 35. So there are probably 2,500 people who are in our age range for risk for psychosis. The majority of them are criminally committed. For DOC, Department of Corrections, males average about age 44, and the range is 18 to 87. Females average about 42, and the age range is 19 to 77. And I couldn't get any data sooner than 2016, the 3-year recidivism rate was 29% for the males and 31% for the females. Next slide. So the other thing that is really important is I mentioned that the population has really decreased in the male section. In 2011, there were almost 12,000 imprisoned men. And the largest decrease, it has slowly decreased since then. And from 2020, there was almost a 2,000 number of inmates were decreased from DOC. So the number is now down to about 6,000, a little more. But they do identify mental illness. And I'm sure these are people who either come in with the diagnosis or you just can't miss it. 38% of the males have an open mental health case. 31% were diagnosed or were described as having a serious mental illness, and 28% were on psychotropic medication. And that was as of the end of 2020. So I found this gender difference to be pretty amazing. Females, 70% had open mental health cases. 67% were identified as seriously mentally ill, and 63% were on psychotropic medication. So that the numbers are huge for females. I'm not sure what to make of that. If vulnerable females are identified by males, because often the females are in some ways victims. They're talked into taking part in crimes or acting as carriers for drugs or things like that. So I don't quite know the difference. I don't understand it, but there's only one female institution, and that's Framingham. All the rest of the institutions are male. So, so just a little bit of information on that. I wanted to give you a quick snapshot of what the Department of Corrections looks like in the state. So there are 15 institutions in Massachusetts. Most of them are within 495. So they're pretty all close together. There's one unit, one institution that's dedicated to substance use disorders. And that does 90 day stays, treatment stays for males only. There's one pre-release center for the whole state. There's Bridgewater for people who are deemed criminally insane and dangerous. There's one institution for sexually problematic behavior. There's one hospital unit that's at the Shattuck. I mentioned there's one female unit at Framingham. There are 2 max units. And max pretty much means you are often in 23-hour a day, 23.5-hour a day lockdown. There's 2 medium security institutions. There's 2 minimum medium, and there are 3 minimum pre-release kinds of institutions. So that largest population from that earlier chart was that there are jails. In the state, there are 19 jails. And as the chart showed, there were almost 10,000 inmates in those 19 jails in 14 counties. There are 2 federal prisons in the state. One is a medium minimum medical center for the country, and that's at Fort Devens. That's for both mental and physical illnesses, for severe mental and physical illnesses. And it also includes violent, difficult to handle cases as well. There's also a medical minimum at Fort Devens, but that includes only nonviolent. And they are really on their way out of the system, have to be employed, they're working towards release. So can we do the next one? So there was a program, it was a family awareness program. It's called Keep in Touch, that was developed by a bunch of social workers who worked at Bridgewater. And in the 80s, Bridgewater, once you were in there, it was kind of hard to get out. I joined in 1991. So as a volunteer there, we had 3 groups. You did not have access to Department of Corrections records. You did not report back to Department of Corrections on group meetings. And the goal of the group was really to provide education about self-awareness, parenting issues, fatherhood, child development, a little bit of everything. And it was really run, even though the groups could have anywhere from 10 to close to 100 people in them. It was really run so that there was a long part of it, there was educational part and part that was for processing and talking about. Next slide, please. So we had a group called Family Awareness for Older Fathers. Nuestra Familia was a totally Spanish-speaking group, and Young Fathers, which were obviously younger fathers. Though in the later years, we often had people, older men from Family Awareness come into Young Fathers, as well as English-speaking Nuestra Familia. Mostly because it depended on how young the group of young fathers were and how much they needed some older men to model how to be in a group. The next one. So these are the kinds of issues and topics that we would spend a lot of time on, from especially anger management, but depression, substance abuse issues, family dynamics, what their primary family was like, how it has affected their ability in the family dynamics that they have set up, their family health issues, their roles of cultural expectations and stereotypes, which actually plays a big role for a lot of these men. The next one, please. So we did often, especially when we talked about health issues, we would talk about the health services. So every prison and jail has a health services center. In Massachusetts, they are bidded out to the lowest bidder, basically. So they are incentivized to not provide services. You basically have to fill out a slip that you want to go to the health service center. You have to write on it why, and that goes to one of the correctional officers. Now, obviously, that leaves you open for people to know your personal business. It was difficult for people to get appointments to be able to go, especially around psychiatric issues, unless they are really very obviously psychotic. Now, there certainly were men in the groups who clearly had thought disorder that appeared to be having psychiatric difficulty. Some were depressed and sometimes dragged there by their friends, because we were seen as a safe place to go and talk. But there was a lot of trust issues about going. Mental illness of itself in the prisons is often viewed as a weakness. So that puts you at risk for victimization if somebody finds out that you have a mental illness or are depressed. The men felt that they were being seen by the DOC as trying to manipulate the system. They were trying to get out of something if they complained or talked about being depressed or having difficulties. There are very few professional mental health providers, very few. And there's also a very limited number of available medication for each of the psychotropic medication groups. So if you were identified and you were tried on a medication, if it didn't work, there may have been one other to try. The men would talk about psychotic symptoms, but they would talk about them really as part of being in solitary confinement for long periods of time. It doesn't take much to get put into solitary. You speak back to a corrections officer. If you aren't fast enough in doing what you're supposed to do, you can get written up, as the words go, and put into solitary. We've had men come to the group who have been in solitary for close to a year. And those men were not in good shape when their friends brought them into the group. Next. So I wanted to put in this slide because more than just basic mental health treatment is needed. Because I would say it's sub basic is what the men are provided with. We need to have education at all levels, from the superintendent down to corrections officers. I could say from my experience going in and out of the prison that my experience really depended on whether or not the corrections officer knew me and if they had developed some amount of trust over the 20 plus years that I was there. If they didn't know me and if there wasn't trust, I was more apt to have a pat down search. The officers that knew us tended to stay out of our groups. They did not walk through as often. If they don't know us, they would hang out, which obviously kills any amount of trust and things. And we could be pulled in right after the meeting to explain why we were talking about whatever subject we were talking about. So again, there's really a need. I would say that over the years, probably in the 20 teens, the officers that were in charge of that meeting building were much more supportive and much more helpful. But we do need an overall change in DOC culture and adequate funding for mental health care and treatment. As you know, I worked in research, and people came to us from all over for research. I do remember one case. It was a 19-year-old young man who came to us from the hospital, and he was hospitalized after getting discharged from about a 6-month stay at a local jail. So I think what's important here is at jail, he was psychotic the whole time. My guess is that his behavior that got him into jail was in response to delusions. He describes the hallucinating, extremely paranoid and fearful, and being delusional the whole time he was in jail. He did everything he could to stay in his bed and to hide out. He was forced to go to, meals and certain activities. But it sounds like his experience in jail was he was very terrified. Even though over time he told us about some of these experiences, he was difficult to engage. And that was complicated by the fact that he was a heavy pot smoker prior to going to jail, and also once he got out. It was difficult to engage him in treatment. We had sort of a day program kind of treatment at that point, and 1 day a week day program. And though he came, it took a really long time for him to have any kind of trust in our system and in our providers. He did stay for quite a while. It was always a struggle for him to take medication and to be part of the group. So I don't know how much of that comes from being in jail. I don't know that it does. But I think he's a typical early uh, young person experiencing psychosis who doesn't really understand it, doesn't want to understand it, does not want to be psychotic, and wants it to all just go away, as you all know.
Joanne,
So,
if you don't mind me asking, so it sounds like the really trust building piece was the first step in here. Can you talk a little more about what that looked like trying to build that up with him?
you know, trust building is very individual, as all clinicians know. Ours was in a context. I was a clinical assessor, so doing diagnostic and clinical ratings. So changing them, the format from a formal diagnostic to to going at their pace, to building in more discussion, to providing over time health education, a psychiatric education. So it wasn't just going in and asking the 18 items from the BPRS, or it really is taking the time to get to know them, for them to get to know you, and to build on that the whole time. It's really the only way to help engage them in the system of care. So you need to be willing to take time to listen to what they're upset about, what they're worrying about, what they're part of it was also doing education, helping them, as you talk about symptoms, learn to identify them. So things like that.
Yeah, thank you.
Rakesh, do you want to take over for your experience? Rakesh has a great experience in a jail system. And I think going from prison to jail, hopefully jail is where most of your young people are coming from.
Let me find my slides. Okay. Can you see my slides?
Yes.
Great. Okay, thanks for allowing me to share our experience, which in retrospect was sort of very, I guess, innocent and naive. But I will just share what our experience was and what we can learn from it. So. Let's see. So, initially when, I was working with On Track, and, we'd have these occasional experiences where someone would get arrested, end up in jail. We wouldn't have any contact for, 6 months, and the person would come out off meds, really in a worse state than they had come in. And it was just this, experience that they were so disjointed, like there's no interaction at all between the healthcare system and the mental health system and the correctional system, where a lot of our young people spend, considerable time in. So initially, when we just, with this idea of trying to see if we can build some bridges, that's how we were sort of initially thinking of doing this. Again, again, the other part we really were concerned with was we discussed this idea of trying to decrease the DUP, the duration untreated psychosis. And if they're spending anywhere from 6 months to 2 years in jail during this critical period, it's really a window that we're losing out on, that we could be intervening at this time. So it was this idea of trying to facilitate this crosstalk and interaction between the correctional system and the mental health system was sort of the idea that we started this project with. So, I was working in the On Track program at McLean Hospital. And so for our county, Middlesex County, the hospital, the jail was the one in Billerica. So that's where we try to make our connections. So this is sort of one of the oldest jails in the country. It's a medium to maximum security facility. And, I learned a lot about the correction system, how it works, what the difference between jails and prisons were. And, the jails, so Billerica has about 800 inmates. And they are about half and half sentenced and unsentenced, the pretrial detainees. And there's a very different population. So the sentenced populations are people who've been sentenced anywhere from 6 months to about 2 years. And they are more of a stable population, whereas the unsentenced, the pretrial detainees could be people who end up having life sentences, or people who'll be bailed out the next day. So they are more of an unsentenced population, more unstable population. And so the jail set told us that about 1/3 of the population had a mental health caseloads. And they, seem a little bit more progressive compared to many other jails that I had heard about. They actually were interested in trying to have programs that are innovative, that would try to tackle mental health issues. They had a special unit for veterans, and that they provided PTSD treatment for. And they had a substance abuse unit. And they also provided medication assisted treatment with methadone and Suboxone. And they also had what they call the young adult offenders unit, which is the idea of keeping the 18 and 25-year-olds, so that in some ways trying to make sure that they don't mix in with the hardened population and learn all the bad things. So most of them are like first-time offenders, but who've been sentenced for anywhere from 6 months to a year or 2 years. So we formed this project. So with the Middlesex Jail, we had a lot of interaction with them, and the person there who was really integral was Special Sheriff Sean Jenkins, who was very instrumental in trying to get us involved. And then we had the support of the Psychotic Disorder Division at McLean Hospital, and Robert Wood Johnson Foundation also helped us with this. And then, so, when I was starting to think about this, I realized that there are a lot of people who are very passionate about this, and so this is, although Kelly Scanlon was a social worker who at McLean, I'd never met her, but as I was talking to people about doing this, they told me about her and really became my partner in this venture. And she, had the additional experience of having worked at Bridgewater, and really had a lot of experience working with the correctional setting previous to this as well. And then as we were doing this, we had a lot of basically volunteers, like the social worker, Sophie, and there was a research assistant, Talia, and another psychiatrist. All of these people they just wanted to come and volunteer to do this. So when we started out, we had this sort of, overall general plan that we set out with. We thought we'd go and do some screening, trying to every inmate who gets, comes into the system, will have just do a basic screening to see are there diagnosed, undiagnosed in psychotic symptoms, any evidence of psychotic disorders. And that we would, take what we have been doing in the first episode clinic to really help with the treatment optimization, working collaboratively with the patients as well as the jail staff to maximize treatment adherence, really having group and individual therapy, and also in helping with case management so that when they leave the jail, they're really connected to the appropriate treatment after release. So that was sort of our initial framework. So we started in spring of 2017, initially got the sheriff's approval to do this, spent the next couple of months meeting with all the different people in the jail, the staff on the ground, to the mental health teams, and the health director, and then so as Joanna had mentioned today, the healthcare in the jail is farmed out. So there's a mental health contractor in the jail. So we went there all eager beaver and said, oh, we're really trying to come and help. We've experienced working with early psychosis, and we can really, these are some of the more difficult patients, and we'd like to help you with that. And there was not much interest or enthusiasm on that front. They were like, no, we really don't need your help. We're actually fine. And I got the basic sense that we were not seen as help, but more as a threat, right? In terms of any sort of in a system that they had that had worked well for them. So they weren't really keen on us, actually providing care. And so it really became that I really need to learn a lot more about how the jail works, how the system works. So since you could not really provide treatment, so what we decided was we would just start some groups, and we started working with the young offender group, which is again this group of 18 to 25-year-olds. Again, not necessarily a mental health unit, but quite a few number of people there did have mental health issues. And we just thought we'd go in every week and we'd run groups as a way for us to know the lay of the land, build relationships, see what the needs are. And so there's we had like 4 groups that we ran every week, and we each of us would go a different day, with a CBT group, communication skills, a mindfulness group, expressive writing groups. So that's what we ended up sort of doing for about a year and a half, just to kind of so we just go there every week, and do this. And so after doing this for about a year and a half, then we decided, okay, we'll have a sort of strategic planning session. And so this is where the Robert Johnson Foundation Center facilitated to help. And so we had, 6 administrators from the jail, 8 staff members from McLean Hospital, and with also, and this was a half-day workshop, and at the end, the sheriff as well as the president of McLean also joined for the last session. With the focus question was, how can we build an innovative and sustainable model for an effective treatment of severe mental illness within the correction systems, with a special focus on young adults with psychotic disorders. So after we had this pretty engaging and great workshop, we came up with a plan. Let's see. Right. So working proposal was to basically make a treatment-focused mental health unit in the jail that's staffed by McLean clinicians to provide the programming, psychiatric treatment, and aftercare planning to young adults with psychotic disorders. So, jail comes with a lot of restrictions about what you can do, what you cannot do. And one of the things was also, if we just wanted to kind of have, a clinic of sort or run groups, you cannot really mix people from different units. So we had to, so that's the way we got around this was the jail said that they would actually give us a separate unit where we can have all the patients, the young adults that we'd be working with. And so the design that we came up with that will have this structured menu-based approach for recovery for young adults with psychotic disorders, initially starting about 20 to 30 young adult inmates with a psychotic disorder diagnosis or symptoms, and that we would have medication management in some ways with the same kind of paradigms we'd be using in the outpatient program. And really for having this individual and group therapy, aftercare planning, case management. So, let me see. So again, we came up with this whole program that, it'll be run more like a partial program in a hospital, in a jail setting. So, and so that we were going to have, 2 social, it's going to be basically run primarily by 2 social workers. And we're going to have like a part-time pill pusher, and then, a nurse educator, a data analyst, was going to be the hospital staff, and the jail was going to provide the director of mental health, unit manager, and corrections officers who would be trained in mental health and also trained mental health specialists. So this is where I think we were just very naive going in about not knowing all the systemic issues, what kind of bureaucratic things would come up. So our initial plan was really to have this crosstalk between the correction systems and the healthcare system. So we were actually going to have the mental health specialists who work in our inpatient psychotic disorders unit really, kind of rotate through the jail, and then so that we bring some of that ethos of how do we treat a young adult in with psychotic disorders into the jail setting. But this was quickly nixed by HR at the hospital saying, oh, the jail staff are unionized and our staff are not unionized, and the twin shall not interact. So they said that was not going to be possible. So that meant that we basically would have to have a separate cohort that would, that would be just working in the jail setting. So, our initial plan was, again, having this ongoing assessment and evaluation of the unit's performance, the training of staff, to iteratively enhance services, programs, and strategies. Again, this was a, a setting that we were not as well versed in. So we were going to bring some of the outpatient learnings that we've had to try and apply that in this setting. But we would, realizing that we would have to have some changes iteratively as we go through the process. And again, soon to see collecting data regularly on the psychopathology rating scales, medication adherence, social functioning scales, violence scales, and also collecting data from the released inmates to assess what their psychiatric, legal, and functional status was post-release. And really using this pilot data to apply for funding both for implementation and research. And we really wanted to follow up with the release inmates every 3 months for the first 2 years after release to monitor the treatment status and function recovery if our intervention would be making a difference. So again, the anticipated outcomes we had was we thought we'd have reduced incidents of self-induced behavior, incidents of violence in the jail itself, which was of interest definitely to the jail administration. We were hoping that there'd be improved medication compliance and stabilization. One of the things with the luxuries that we have in jail is that we have the luxury of time. Right now, we really have most of these patients are sentenced, from 6 months to 2 years. So we really have the time to work with them, come up with a medication regimen that they're comfortable with, that the side effects are, well controlled. So with the hope that they would then continue on with that after they're released. And there's also the reduced transfer to Bridgewater State Hospital, which is the maximum security forensic hospital, if we can decrease the levels of acuity. And this is, I think, a big financial burden in the correctional system every time someone's transferred to Bridgewater. So they were very interested in that. One of the things they did in the correction system is there's Bridgewater and there's jail and there's nothing in between. So when they send to Bridgewater, again, there are fewer beds to begin with. They get sort of, quickly patched up, stabilized, and then sent back, and then they're back into the same setting in the milieu with the same kind of, acuity. And so that is where I think there was the lack of this buffer between Bridgewater and the jail population was a big problem for them. And our hope was also having this separate unit would also reduce disruptions in all the other jail units with patients who were agitated, psychotic in the midst of all these other units. And we're really hoping for this successful and coordinated transition back to the community, hoping that they would have reduced recidivism of incarceration due to issues related to untreated mental illness. So after this thing, so summer to fall 2019 was where all the the bureaucratic stuff happened. There were numerous meetings between the McCrin administrators and the jail administration to flesh out the details, the development of mental health unit, and again, this is where all the middleman and the bean counters and everyone got involved. What are the indirects and what is paying the money? And this was just way above my pay grade. And but finally, after going around this, so we worked on this almost for 3 years, and eventually the project was nixed by the hospital. No, it was never clear to me exactly what the reasons were. Different people gave me different reasons why it was, but the official reason I was given was that the jail is under the jurisdiction of DOC, whereas McLean can only provide care for facilities that are licensed by DPH. So for that reason, you cannot do it. I don't think that was the main reason, but that was the official reason that was given to us. So eventually we ended up, disheartened and discouraged and, had to abandon the plan. So again, I think what we took from this was, again, there's many systemic challenges that makes this a difficult area to tackle for, again, we were just like a bunch of naive clinicians who were really eager to do this. But I think we just, did not realize the level of systemic and bureaucratic roadblocks that would be in the way when trying to do this. And the main thing for us is I think we really needed committed partners who have an innate interest in reaching underserved populations. and with the political and financial resources for implementation. I think we really, in some ways, McLean was, in retrospect, not a great partner. Again, they're primarily an inpatient hospital on top of Bellman Hill, right? I think not a healthcare system with a track record or an inherent interest in working in the community, doing working with underserved populations. And also, I think need a more concerted effort in collaboration with DMH, DPH, and DOC. So in the early part of this thing, I had gone to talk to DMH, and I was thinking this is a great idea and stuff. But when they're in jail, they're really under DOC. Now, when they come out, we'd be interested. But when they're in jail, they're really under DOC. And the other thing that we also found out was when we were initially had gone to jail, we said, look, we can really help with the aftercare planning. With the social workers who've been working in inpatient units, they're used to like placing people in different programs, and that's really something that we can do. And they said, oh, you guys don't know how this works. It's not gonna work because to set up appointments with anyone, you have to have your like a Medicaid number. And when they're in jail, their Medicaid is canceled because to avoid double dipping. I don't know how you double dip when you're in the jail, but because they're under the DOC health system, so their mass health gets deactivated, and it gets reactivated a week before they're discharged, and then they're given appointment with a PCP 2 months from now with the instruction to follow up with a mental health or something. Which again, it's a good luck with that, right? So I really feel like, that there are so many of these systemic issues that I think we as clinicians really find it, we are really helpless with. So I think after all this, I think my sort of, recommendation would be really that, since we've had really so many different FEP programs that have really, been set up now in so many areas around the state, it would really be a great idea to pilot the FEP program in a jail. I think providing FEP services while those, young adults are incarcerated, this is really a golden opportunity. They're really a captive audience, literally, right? And you have like 6 months to 2 years to really work with them, and the no-show rate's going to be very low. They're right there, and I think it really gives you a chance to develop the relationship, develop the trust, and develop a good working relationship that, that they'll have a good relationship experience with mental health care providers, so that they're more likely to follow up with, I think, a mental health treatment after they leave the jail. And also, I think the period right after they leave jail is also important, right? I think that's a time to have this collaborative bridge clinics that include both the mental health staff and the criminal justice staff. And a lot of them will be in parole. And I think really trying to maybe have a place where, like, say, Thursday afternoon is going to be both parole check-in and mental health check-in, right? So I think if you can coordinate, have a place where you can provide both those services during that transitional phase, and really with the idea that we'll coordinate the transition to outpatient FEP sites once they're through with that. So that's sort of in a nutshell what our failed effort was, and hopefully it will spur some discussion and from people who may be more knowledgeable about the systemic issues, about how we may be able to do something about this.
Well, yeah, thank you both so much. I mean, I think you brought up a lot of the key points. And as Rakesh was saying, please feel free to unmute if you have a question or put something in the chat, Alyssa, and I will keep an eye on that. I'm curious, just something that stands out to me initially, Joanne, from your case, and then Rakesh from parts of the things that you're saying, is it seems like there are these inflection points. So either when somebody first enters the system or is transferring between systems or is leaving, that there's discontinuation or gaps or things that could maybe be more thoughtfully done to help people get into the services they need. I wonder if either of you have thoughts on what potential things could be done in those points of time.
I think, it would be really great. We have substance use diversion programs. So the diversion actually happens before they go to jail. So they go to treatment centers. So to have that for serious mental illness, for first episode or early psychosis, and have judges and probation and all that whole group on board for diversion to treatment programs would be, I think, ideal, since some of them get themselves into trouble due to their psychosis, but also due to their substance use and other things. But some kind of diversion beforehand. There's a lot of, lack of a better word, bad learning that happens in jail and prison. You learn skills that you don't need to have to function and do well. So I would like to see it happen way earlier. But I think as they're coming out is also critical. Maybe Rakesh, you can say something.
But I think it's actually, you know, there are some diversion programs. It's just that I think many people don't know about it and don't know how to access it. Like, you know, I actually have a patient who, you know, in his psychotic state ended up, you know, his acts ended up leading to the death of a person, right? But, you know, he, you know, had, you know, parents who were resourceful and were able to get lawyers involved and really was able to get his case go to the mental health court instead of, and so he ended up not going to jail at all. And he really, you know, to this day, he still has to, like, you know, right now it's by Zoom, but check in with the mental health clinician, you know, every 2 weeks. But, you know, that was really, and then, you know, so he's now back in school full-time, getting you know, GPA 4.0, right? And that is something that is, you know, available only for people who have the know-how and the resources right now. And how, you know, even I didn't know of these resources until actually his parents told me about how they went about doing this, right? I think so. I think that's definitely critically important. How do we divert them early on before they even go to jail so that they don't end up going to jail? I mean, having said that, there will always be a subset of population that will end up in jail, you know, just the nature of a correctional system, right? You know, it is. And I think really have to have a multi-pronged you know, effort. One, again, trying to avoid sending those patients into jail. Two is when they're in jail, how do we really make sure that they are being treated? So we're really trying to tackle the DUP issue while they are incarcerated for anywhere from 6 months to 2 years in the cases of people based in the jail population. And then the third is when they leave, how do we, you know, not have them fall through the cracks? How do we actually, you know, make sure, you know, right now, if you try to find a psychiatrist who takes insurance in Massachusetts, good luck. If you have a, you know, psychotic disorder, it can, you know, adds a layer of, you know, another layer of difficulty. If you have a criminal record, that makes it like, you know, so even, you know, in that kind of setting, how do you really set up these things so that people don't fall to it? These are really systemic issues that are not going to be easy, I think, to tackle. And it really needs a concerted effort, both from the clinicians as well as from the different agencies.
Yeah, and
So-
Hannah, thank you for putting that in the chat too. Can you speak a little bit more to that program at BMC?
Yeah, thanks, Rakesh, because it's something we're a lot of the things that you're saying is what we're thinking about in BOAT. So BOAT stands for the Boston Outpatient Assistant Treatment. So we have BMC through funding from SAMHSA has a partnership with the Boston Municipal Court. And it's a little bit separate from mental health court. And I am involved primarily taking care of the individuals with psychosis, serious mental illness, but psychosis, early psychosis, individuals who have multi-episodes of psychosis as well. And basically the goal is to get avoid jail and help with services, like wraparound services, with a coordinated team. And there's a lot of overlap between the RAP program and the VOTE program, which is why I've worked in both. So on the team, there's a case manager, recovery coach, myself, psychiatrist, and addiction psychiatrist, peer specialist, care coordinator, to really help individuals with treatment in a cohesive manner. What happens is they'll get involved in the court system, and then be referred through, the judge can refer to the VOTE program as part of their probation. And obviously we don't have mandatory treatment, but it's part of the probation to fulfill the requirements of these different aspects of care. And depending on how long the person is on probation, so it sort of depends on how long they're in the VOTE program. And then we have weekly team meetings, not similar to sort of coordinated specialty care, to coordinate the individual's psychiatric care depending on their needs.
Yeah, I have, first of all, thank you for the insights, Joanne, good to see you. And I had a question for Rakesh. Your experience is very, very illuminating in terms of attempting to implement a service at a correctional facility. So I wonder whether, the experience in, your experience was not entirely, as per your own goals in terms of the success. To what extent did your team involve a top-down approach of educating and informing the higher levels of leadership of DOC and DMH and involve them in the resource allocation and implementation of these services?
So I think we definitely engaged with the DOC leadership first. We figured that this was not going to happen unless, especially the jail leadership and the sheriff who were going to be. So we really started with them and got their, I think, support, politically, to really be able to even start this venture. So that, I think, the DOC part went pretty well. And they, I thought, were probably the most committed of all the partners in terms of even the resources at the end. They were willing to put in the resources that they could, given the whatever, sort of legal constraints that they have. So again, all the jail personnel expenses was going to come from them. And even some of our expenses, something that they can do without having to go to the legislature, they were willing to provide. But it was, again, you can get stuck in so many different paths. And for us, I think it was the hospital that let us down, from my perspective, right? I think it was just the wrong partner. And then the other part, I think, was maybe I think there's more of this involvement with DMH now. Again, I think at the time when I talked to DMH was, again, there was almost a separation of, jurisdiction in some ways, right? And I think, but I just feel like I think DMH and DOC really have to work together on this, because these are people going to be cycling from one to the next, and then each time, one is in one jurisdiction versus another, I just feel like need to be, that's why I had this whole idea of, is there a possibility of actually piloting an FEP program in a jail setting to see how that would work? What are the logistical, systemic, political, bureaucratic things that we'll need to, go through? Again, it's something that I think me doing this as an extracurricular activity is not gonna solve. I think would require a little bit more of a systemic approach, and I think really more of I think interest at the higher levels of DMH and DOC.
So yeah, it seems to me that the buy-in for making a movement forward, from the top-down levels would be strong if there was evidence that could be shown that this kind of interventions would actually reduce recidivism and improve diversion and overall reduce costs and so forth. So that might call for maybe some pilot projects, so that if maybe SAMHSA or some project mechanisms could be a good first step moving forward.
Well, and it stands out to me too. I mean, Joanne, the numbers that you showed at the beginning were pretty striking of just the percentages of people who do have some, identified mental health concerns, not even, undetected or something that they're not disclosing to people, but really diagnosed mental illness in the system. I mean, to me, that kind of points to the fact that the correctional systems are mental health systems in kind of their own way. So yeah, I think Rakesh, your point about getting more overlap there, that's really a way to advocate for that.
So the way I came after this, another thing I did for a while after this was actually to write a grant proposal. I just felt like if anyone wants to do like a common sense, obvious thing, there's no funding, but if you couch it as research, then, then you can actually maybe get it funded was the thing again. So we were not doing this on a large scale. The whole idea of this was really to generate some pilot, experience, pilot data, that would then be, I think, a source for both saying what is effective, what is not effective, and potentially, implementing that in a lot. And this was, again, just a small program in one jail is what we were proposing to do. And how do you get, the resources to do something at a small scale like that? Because again, the thing is that there isn't a whole lot of data. So we kind of have to generate the data. We have to collect the data. And how do you actually, use this common sense approach that if CSC works, pretty well in the general population, there's a, pretty good chance that it's going to work, if maybe even better in the correctional setting. But, but I think to do that initial step, I think is where I think there's a lack of resources to be able to implement the pilot project in some ways.
We're collecting a lot of data, and we could look, at intervals with different outcomes. Obviously, we could talk more, but we can look specifically at individuals who are early in the course of psychotic illness and who have this robust intervention and then longitudinal outcomes. Because right now we have a 3-year funding, so we'll be able to generate, I think, some helpful data, perhaps for other projects.
Yeah, so some data could even be generated from the regular community coordinated specialty care service studies. For example, the kind of pathway analysis that we did in the DOP study between us and the Yale, we would have information on the duration or the path or the number of nodes, which include to care, that include correctional settings, and whether a public intervention like public campaigning reduced the degree of criminal or correctional facilities as a node in those pathways was reduced. We may even have answers for those kind of questions from existing data. One could look at the RAISE data, for example, between control and CSC interventions and so on. How did the different studies do in terms of pathways to care, for example?
Also, in Bridgewater, there's the companion program. You're familiar with that one? I think it's a peer counselor while in prison program. So that if you incorporate that CPS kind of data or into the incorporate CPS into the CRC model, I think they've been working for years now, training people. Every training, there's people from the companion program at Bridgewater. So I'm assuming that they have some data there that might also be helpful.
I think a helpful point from Melissa here in the comments too, that we have the MapNet data. We do ask some questions about criminal justice involvement, the extent to which we have, robust data on that, we can look at more, but we do see lower engagement. And Alyssa was doing a project. I don't know, Alyssa, if you want to talk more about that, but on kind of looking at barriers to engagement.
Yeah, that's right. So, statistically significant lower engagement. And there's a lot of ways we can go with that, but definitely like an indication that, the way services are offered may need to be adjusted, especially if we're thinking about people who have meetings with parole officers or other certain obligations that might make it harder to engage with care as it currently stands.
I wonder, it looks like Emily has to sign off, but if you guys can speak to the point that she brought up in the comments here, thinking about the relative strengths of having an academic medical center, first episode clinician go into the facilities versus being trainers and consultants for the mental health system in there.
Right. I mean, we started out with trying to do the latter, right? I think we really didn't go out trying to do a full-fledged mental health unit. But I think the problem with the second approach was really that you need a partner who is willing and interested to partner you with. So in our case, the jail leadership was very interested. The boots on the ground, the correctional staff were very interested. But the mental health contractor, who actually is the one doing it, they were least bit interested, right? This is where I think for us, that's why we ended up going to the other model where we just had to do a separate thing on our own, because we said, look, we're not here, we cannot take care of all your caseload, but we can take care of patient with psychotic disorders, especially the young adult psychotic. That's our area of expertise, and we're happy to provide consultations. And they're like, why do we need your consultation? Was there kind of, we can do this on our own, was there kind of, thing. So I think, I think it's definitely a reasonable approach, and it's actually less and need for resources if we can just serve as consultants. That's really what we wanted to do going in. But again, for that, it may work depending on the setting, but I think just given the fact that they are mostly taken care of by contractors who don't necessarily have, I think, that inherent interest. So that, I think, is the roadblock that we faced in trying to do that second approach.
And then, one more thing that comes up for me, I know when we were talking about this before, we talked about there's this much wider mental health system for first episode psychosis, and people interact with these different systems, but that having improved interactions with that mental health system early in someone's relationship or in their experience of psychosis can really be a part of their longer term engagement, post release from the correctional system. But, really, that's a very critical piece of DUP that is maybe not as focused on right now. So I wonder if you have other thoughts in that area too. I think that's most relevant for the first episode clinicians here who, are doing the work. And you mentioned your case of somebody who had a hard time engaging just because of those trust pieces.
I don't know. What I'm thinking about though is I don't know the mental health diversion clinics at all. And maybe Margaret, more about them. But whether or not they would have a way of being trained or letting trained clinicians in to particularly pick out young first episode and to identify them for specialized treatment.
Yeah. I'm so glad that we're having this meeting this morning. And it's something that clearly we need to spend a lot more time sorting out together. Prior to the pandemic, I had started some very preliminary conversations with some of the clinicians that work in the prisons. And it's clear from them that some of them feel very confident and super comfortable recognizing and responding to people with early psychosis, and others, what they would say is that the demands on their time, this is what I'm recalling from a 2.5-year-old conversation, but that the demands on their time, the urgency around opioid overdoses and other kind of things take up all of the sort of oxygen. And so although they recognize the need and they feel like they have some expertise, it's not the most pressing, urgent kind of front and center crisis, and they're always dealing kind of in crisis mode. That being said, I was sort of putting in the chat, there are a number of programs and resources that our forensics division operates, really trying to address many of the very concerns that you've highlighted. You and Rakesh, thank you both, have highlighted today. And I think they are very open and wanting to sort of, we need to bridge, I'm a bridge, but I'm not a great bridge. I'm a fragile bridge. We need to sort of strengthen the bridge between this work that we're talking about here and that we're doing in the early psychosis realm with the DMH forensic services. And then sort of, because they are the ones that work very closely. They're in the mental health. They're in the courts doing court evaluations. They're doing the mental health courts. They're doing the ride-alongs. They oversee the ride-alongs with the police when the police are responding in the community. They operate the forensic transitional team, which is when someone in prison or jail has been identified as a DMH client. I'm fairly certain someone who's in prison can apply for and become a DMH client, but that's a little opaque to me. So there's a lot. It's as I think Rakesh, you were saying, that sort of the resources that exist are not known. And so it's only it's by fluke that someone comes to know that there's a resource that could potentially make a difference. So I think there's a lot of work to be done. And I'm just really grateful for this kind of springboard conversation.
Joanne and Rakesh, first I wanted to thank both of you for this incredibly informative, important, and engaging presentation today. And Rakesh, I wish you good luck with implementing some early psychosis program into the prisons, because I think it's really important and can be extremely helpful. So I really hope there's a way to overcome some of those barriers you were talking about before. And I guess another question I had for both of you was just, in terms of, as early psychosis clinicians working in different clinics, are there particular factors that would be helpful for us to keep in mind in our work with patients who have early psychosis, who have prison histories, that are above and beyond the considerations that we normally try to take into account in our work? I mean, I know you addressed some issues related to trust, but are there other things that we should be keeping in mind that would be helpful in our work with these patients?
I mean, I think, when people go through the correction system, different people have different experiences, right? And, some just go through the motions and come out, and, I had one very, very sweet patient, but like when he got psychotic, he would get very agitated, and then he ended up, in jail assaulting a corrections officer, which again doesn't go very well. And he became he was in and out between like jail and hospital, and unfortunately a year ago he ended up killing himself. So I mean, I always take a very personalized approach to each patient. I think each patient experience with psychosis itself, their own sort of, belief systems and experiences with mental health. And so I don't really have, I don't know, overall overarching theme more than that, I really have to take the patient where they're at in terms of what they have been through, what they are willing to do, and what their current understanding of their current situation is. And so, again, I think being mindful that they may have had pretty traumatic experiences while in jail, that again, with some of the things that Joanna mentioned about the trust issues, that may come up as well, right? And so I think those, and again, the other thing in jail is also there's very limited options, right, in terms of like medications and whatnot. And I remember once, like in this unit, that I was running a group, and we tried to do some, it's psychoeducation light, and then there's one person who was on like 30 of olanzapine, and he said he's just sleeping 8 hours a day. He just cannot stay up. And I said, well, the next time you talk to your prescriber, see if you can reduce the dose, change to a different medication. And then, so I guess that apparently didn't go through very well. Then I got a complaint the next one saying, like, we're providing medical advice to the inmates, and that's not, okay and whatnot. So, I think it's just, it's a very, very constrained system with lots of different rules and regulations. But again, I think maybe just inquiring with patients about what their experience with in jail was like, what it was like. So you kind of get a sense of, was it a very, very traumatic experience, or was it something that, they kind of, ended up 2 months of, just going through the motions. So I think.
It seems like one potential starting place would be to pull together people from like the boat program and from the mental health clinics, and try to figure out who are they getting, what are they doing with them, what are the services needed, what else could be helpful. I can't imagine the mental health, and hopefully it'd be nice if I'm wrong, but I can't imagine that they're identifying all sort of first episode or early psychosis, or even psychosis. So who are they identifying? I don't know anything about the program, so I'm just wondering, so getting them to talk and figure out how to, build on Hannah, the program you're with, which sounds great, and working with probation.
Also, maybe a chance to have in some ways, like the peer specialists we have. I think having like a cohort of peer specialists who have had the experience, right? I think, again, for us, we'll always be people who've never experienced that. We don't know what, it is like to be in jail, what it is like to be, they have all kinds of, the other thing I found out in jail, dinner is at 3 o'clock. So after 3, like that's your last meal. And so all those kinds of, idiosyncratic things that, people experience in jail. And I think having, maybe even trying to see if we can train, a small number of peers who have had, experience with the mental health system, maybe another way to try and, help bridge some of those gaps, say, in terms of, the trust gap, that, in terms of having them, again, even for us to understand what some of the issues may be that we're not aware of.
And there are precedents. There used to be the street workers program, which were all men and women from jail or prison, and then they worked with young adults and gangs. I don't know if they're still funded or they're even still available. But they worked with gang populations throughout the state, I believe. But I know definitely in Boston, to try to divert people from gangs and to get them on different paths. But that's another, that's been done before. So there can be, a lot of learning from having a peer program, as you suggest, people that have come out of the DOC system, and then having them engage, because that does help.
lucky enough, I have experience as a peer specialist with both Bridgewater. I was sent there 4 times in my life, and Barica House of Correction. I was sent there way before they implemented veteran programs and everything else. You know, that's what they did to us back then. And Joanne, I think your thought was the best. Stop it before they go in jails. Maybe at the court, there's a brief diagnose or just an overall look at somebody's situation and maybe say, well, he doesn't need to go to jail. And if, you know, we continue incarcerating people the way we do in the United States, maybe take an example from overseas. They changed how they incarcerate people. It's not so much as punishing you anymore, and they leave the doors unlocked to criminals, and the criminals have a different experience once they're in jail. And, you know, instead of always punishing people, as I felt in my years, you know, have a different approach to people.
Right, and that you need a huge buy-in from DOC. So the officers over the years I was there were some that were very pro-treatment, and there are others that were totally punishment. So it really varies. But yeah, I think, you know, the other thought that comes to mind is in these mental health court clinics, when they do an assessment, I'm wondering how open people are feeling, how much they actually divulge, how much they actually tell. Because certainly in my experience, for people, the more it's sometimes very difficult to get a sense, and it isn't until you've worked with them for quite a while that you suddenly start hearing about the hallucinations and the delusions. So
there was a program at Cambridge Courthouse before, alternative sentencing, and they looked at people who were, you know, not bad people, but might have been misguided or misguiding themselves for a while. I think it, like a lot of other programs, just faded away.
I wonder, and Margaret, this might be a later discussion, but I don't know how much we have something like jail diversion programs included in our strategic plan, but that stands out to me as a specific place where we can kind of advocate for, you know, intervening in those important pieces of the system, which clearly seems so closely related to the kind of first episode care that people are giving.
Yep, I think that's an excellent idea.
you know, the other thing, the programs that I ran, we didn't call them peer specialists because we didn't have that word going back that far, but we trained the men to run the groups. We would provide the education and what they needed, and there was a lot of man on man helping, especially those that were really struggling, and especially the younger men. To the point of some of the men, if they found out someone couldn't read, we're teaching them to read, using even things on TV like Sesame Street. But they were helping them, each other, with anger management, with how they look at things, sort of that gang culture, how to get out of that. A number of our men were in for life, but a lot of them were discharged or released, whatever the correct word is. But yeah, getting some of those, and some of the men that were in our programs did go to the street workers program. But
there was an AA group in SECC called Bottom of the Barrel, and the guys who've been around for a long time try to straighten you out. And they were big guys because they were lifting a lot of weight back then.
Yeah,
And,
some of
you
them
know,
are
you
very
listen
big
to them
guys.
because they've been
Yeah.
around the block.
Yes, that's true. But they have a lot of wisdom, and they've been through a lot of time in solitary before sort of getting their act together, and then we're more than willing to share. So yeah, I think even developing post-prison some peer groups or whatever. I'm not sure what the format would be, but it has been used in the past and been successful.
And I was sorry to hear Rakesh had that issue at Barica House of Correction, which was a good start for me. My overall experience was nice because I was hurting myself on the street. So I went in there and was able to stay off substances for a long period of time. It was helpful.
I mean, I think my experience with Billerica was great. I think, and the leadership, the correctional staff, everyone, I really had a great interaction with. And I think the reason the program didn't come to fruition was not their fault. It was the hospital's fault. You know, the hospital decided at the end that they wouldn't let us do this thing. So I think that was where the impediment was for us. And the only glitch in the Billerica system for us was sort of the mental health contractors weren't as keen on us being involved, right? And so, but I think as setting that to pilot something like that, I think Billerica is a great place just because I think they are forward-looking, they're progressive, the leadership and the staff are very attuned and interested in this arena. Again, I just judging by what I read and stuff, like if you say something like Bristol or something like that would be a disaster to try and do something like this because the sheriff and the leadership are very hardened in terms of their approach. So I think in some ways Billerica, this that's why initially I had thought Billerica would be a good place just because of I think the buy-in from the leadership as well as the staff.
And wasn't Barica supposed to put up a woman's dorm or something?
I don't know. I think it's all male right now.
I believe it's all male.
Yeah.
I thought they were going to put a woman's detaining center there or something. Thank you both.
You're welcome. I mean, I don't know what other facilities are around for women, but given the percentage of identified serious mental illness issues at Framingham, that's also seems like a huge need. I'm really not familiar with, what other correctional related facilities are available for women. It didn't come up when I searched around jails that there were, though there may be units in jails for women. I don't know of any. Doesn't mean they don't exist.
Well, I know we're getting close to the end of our time here. I think we have time for one or two more questions. So I'll open the floor to that. Does anybody else have a question they wanted to bring up today? Otherwise, I will echo everybody's sentiment here. Thank you guys so much for joining us today. I think that it's a very valuable perspective on something that we're really just starting to get more, dig more into, and really think about how everybody on this call in their respective roles can be a part of supporting young people who are going through these issues. So really appreciate you guys joining us today. I do not think this is the last conversation we'll have on this topic. So yeah, everyone, please feel free to stay in touch around thoughts or issues on this. And thank you all for sitting through through 12:30 today.
Thank you
So
much.
thanks
Thank you for
everyone,
having
and have a
us.
good weekend.